Welcome back. We're going to do a clinical review of some cases that I've seen over the last 30 years or so. This is my brief biography, and I have no disclosures that are relevant to this talk. So the objectives of this presentation are that learners will be able to apply principles of dialysis-related care to the overall management of dialysis patients, identify atypical cases of renal osteodystrophy, describe the principles of dialysis de-escalation, manage acute hyperkalemia in a hemodialysis patient, lists medications that commonly cause altered mental status in dialysis patients, explain to patients the risks of high interdialytic weight gain, manage chronic kidney disease associated pruritus, and define dialysis disequilibrium. There are 7 cases. I hope that we'll get to them all, but if we don't, then you can use the additional cases as self-study. So let's start with the first case. This is a 33-year-old man with end-stage kidney disease who presents to the emergency department with pulsatile bleeding from an AV graft in his left arm after hemodialysis earlier that day. 1 week prior to presentation, he had been evaluated by his vascular surgeon for a presumed skin infection over the graft and had been started on vancomycin. The patient was incidentally noted to have painless swelling of his left mandible of 6 months duration. He also complained of back pain for which he had been taking hydromorphone that he had obtained from a friend. His past history is notable for end-stage kidney disease due to biopsy-proven interstitial nephritis, hepatitis C, hypertension, asthma, substance use disorder, depression, and anxiety. His medications included antihypertensive medications, narcotics for his chronic pain, sevelamer, vancomycin, and erythropoietin. On physical examination, he was hypertensive and tachycardic. He had a low-grade fever. His chest was clear. He had a regular rate and rhythm, benign abdomen, no peripheral edema. He had no active bleeding from his AV graft, but he did have notable left mandibular swelling. This is a photograph from the inside of his mouth. Laboratory data included a white count of 4,200. Calcium was 9, phosphorus was 8.1. He was a little bit anemic, hemoglobin of 8.7. AST and ALT were 24 and 26 respectively, and his alkaline phosphatase was 291. So the patient was admitted to the medicine service for treatment of a presumed dental abscess. Antibiotics were broadened to include gram-negative coverage and anaerobic coverage with the addition of levofloxacin and clindamycin. So the specialists come riding in. He's seen the next day by the nephrology fellow and the attending who are skeptical of the diagnosis. So what additional diagnostic laboratory tests do they request? Is it blood cultures, sed rate, ferritin, ANCA, or a PTH? Please vote. And I see a few more votes coming in for PTH, second number highest votes coming in for blood cultures. And the answer is PTH is what we requested. This PTH turns out to have been 2,190 picograms per ml. So we got further history of his from his dialysis records, which showed that his PTH had been greater than 2,000 for more than a year. He had been prescribed cinacalcet, but he had never filled the prescription. Vitamin D analogs had been held because of persistent hyperphosphatemia. He had been referred to an endocrine surgeon for consideration of parathyroidectomy, but he had never kept the appointment. So this is from a publication that we did regarding this case. So this is not this patient, but it shows what is called a typical rugger jersey spine. And you can see here the end plates here having these radiolucencies. The rugger jersey spine describes the prominent end-plate densities at multiple contiguous vertebral levels to produce an alternating sclerotic, lucent sclerotic appearance, which mimics the horizontal stripes of a rugby jersey. This finding is pathognomonic of renal osteodystrophy in the setting of hyperparathyroidism. So this is a similar case. This is not this patient, but a similar patient who had mandibular swelling as a result of significant hyperparathyroidism. This is from his bone biopsy, which showed tuberculae of vital woven bone set in a fibrous cellular fibrostroma. And there are these seams of variably calcified material rimmed by scattered plump osteoblasts noted here. So in follow-up, this patient never presented for evaluation for parathyroidectomy. His hyperparathyroidism became progressively worse with debilitating back pain and muscle weakness, such that he became wheelchair bound and he died at the age of 38. So I want to present a follow-up case, one that I saw about 2 years ago. This was a 68-year-old woman with end-stage kidney disease of undetermined etiology who had been on in-center hemodialysis for 10 years, and she presented to the hospital after a fall at home. She complained of neck pain, and she underwent CT imaging of her head and cervical spine. CT findings were noted as no acute intracranial findings, no acute fracture or traumatic malalignment of the cervical spine, but there were focal lytic lesions involving predominantly C1 through C5, vertebral bodies, and posterior elements, new since November of 2022. The findings can be seen with multiple myeloma or metastasis amongst other etiologies. So this is taken directly from the medicine team's note. They note that she had these focal lytic lesions in her C-spine, incidentally found concerning for multiple myeloma versus metastatic malignancy, with an SPEP, UPEP, free light chain, SED rate, CRP, and we'll discuss age-appropriate cancer screening with her. The important thing here is that the medicine team told the patient that she likely had a malignancy. Well, the next day we saw the patient and we reviewed her outpatient nephrology record. And guess what? Her PTH was greater than 4,000 with an alkaline phosphatase of 313. So the take-home message here is that the medicine teams may anchor on a diagnosis because of either a lack of knowledge of dialysis-specific alternative diagnoses or the lack of access to collateral dialysis history. So we as nephrologists must consider and weigh in on the whole patient and always review the outpatient dialysis history from the outpatient unit because there's very helpful information that is contained in that packet of information. Okay, let's move on to the second case, which is going to take a slightly different focus. This is the case of a 51-year-old man with no significant past medical history who presents to urgent care with left leg swelling and shortness of breath in August of 2019. He had not seen a doctor in more than 20 years. Clinicians concerned about pulmonary embolism and refers him to the emergency department. He had a CT for pulmonary embolism that was negative and lower extremity ultrasound that was negative for DVT. His blood pressure on presentation to the ED was 224/117. His family and social history is notable for no family history of kidney disease. He is a former smoker, but he quit smoking about 9 years prior. And he's a man who has sex with men. On physical examination, he was well appearing, no acute distress. He had conjunctival pallor, clear lungs, no pericardial friction rub, soft benign abdomen, no peripheral edema. He had ecchymoses on his left lower extremity, on the lateral aspect of the popliteal fossa with the associated swelling and pain on palpation. His labs were notable for a B1 of 109, a creatinine of 11.59. He was anemic with a hemoglobin of 8, phosphorus was 8.5, and NGAP was 25, and his NT-proBNP was greater than 70,000. Additional labs included negative ANCA, normal complements. Serologies were all negative. This was his renal imaging. His right kidney was 10.7 centimeters and his left kidney was 10.2 centimeters, both with increased echogenicity. So it's increased echogenicity of the bilateral renal cortices consistent with parenchymal kidney disease, chronic parenchymal kidney disease. So his blood pressure was controlled with labetalol and plans were made for a tunnel dialysis catheter. So what do you think? Would you biopsy this patient? Yes or no? Please vote. So interestingly, there are more votes coming in for a biopsy, which is actually what this patient had. Although I think if I had been caring for this patient initially, I probably would not have biopsied this patient, but he did undergo a kidney biopsy. This is the H&E from this biopsy, and what you can see is that the vessels are pretty impressively thickened, narrow lumen, and there's a lot of chronic interstitial disease here. The glomeruli look somewhat ischemic. Trichrome stains shows a fair amount of blue staining in the background, indicating chronic fibrosis. And this was the pathologist read: severe vascular sclerosis with severe arteriolar remodeling, with focal onion skin lesions and extensive glomerular capillary wall remodeling, most likely representing a healed or chronic thrombotic angiopathy. And there's acute tubular injury with focal tubular necrosis, likely ischemic. Advanced chronic changes of the parenchyma, including advanced tubular atrophy and interstitial fibrosis, about 80% of the cortex. So based upon this biopsy, does this patient have end-stage kidney disease requiring long-term dialysis or acute kidney injury with the possibility of recovery of renal function? Please vote. Vote for ESKD or for acute kidney injury. So it looks like most folks are voting for end-stage kidney disease, which is what we thought he had. So the patient was started on hemodialysis via a tunnel catheter. He stabilized with good blood pressure control and was referred to an outpatient dialysis clinic in another state to be closer to family. He returned to Boston in November 2019, which is where I met him. In January of 2020, he had a PD catheter placed and began training for PD. Clinically, he does very well on peritoneal dialysis, and his prescription was 4 exchanges times 2 liters over 9 hours. So if we look at this patient's solute clearance, we can see what happens here in terms of his urea clearance and his serum creatinine. So you can see he starts out with a serum creatinine of about 7.9, but by December 23, his serum creatinine is about 3.7 without any significant change in his muscle mass. If we look at his urine volume is actually maintained and actually begins to increase over time. And urea clearance, for what it's worth in peritoneal dialysis, and that's a caveat which Dr. Bargman will talk to you about this afternoon, the limitations of KTRV urea in peritoneal dialysis. But you can see that his total KTRV was always at least our minimum target of 1.7. And in fact, by December of 2023, his renal KTRV alone was greater than 1.7. So as his residual renal function improves, which of the following strategies might you use in de-intensifying his PD prescription? Would you give him weekends free from dialysis? Would you do fewer exchanges? Would you do a smaller fill volume? Or could you use any of these strategies? Please vote. And it looks like 100% have chosen the correct answer, which is you could use any of these strategies. So we chose to give the patient weekends free from dialysis. When you do that, you have to remember that the calculated peritoneal KT/V that your dialysis company is going to give you assumes 7 days per week of dialysis. So we need to calculate what his KT/V is with 5 days of dialysis. So in order to do that, you need to know what the dialysate urea is, what the BUN is, and then calculate the D/P urea. You need to know what his total body water is, and you need to know what the drain volume is. So if you take his drain volume, multiply that by the D/P urea, and divide that by the total body water, and that gives you the daily KT/V. In this case, it's 0.14. Multiply it by 5, and that will give you his weekly KT/V with 5 days of dialysis. What about his renal KT/V? It's a similar calculation, except you need to know the urine urea nitrogen, which in this case was 428. B1 is 53. His urine to plasma urea concentration is therefore 8.1. Total body water is the same. Urine volume is 1.4 liters. So you take that urine volume, multiply it by 8.1, which is the D/P urea, divide that by the total body water, and that gives you the daily renal KT/V. Multiply that by 7, and then that gives you his weekly renal KT/V. So his total KT/V with 5 days per week of PD is 1.9 plus 0.72, which gives you 2.62 with 5 days per week of PD. So in follow-up, this patient's renal function remained very stable. His BUN was 45, his creatinine was 3.7. His KT/V renal KT/V was consistently greater than 2. His albumin was consistently greater than 4. He had no ESA requirement, no phosphate binder requirement. So we ultimately made the decision to stop dialysis. His most recent BUN and creatinine were 64 over 3.69, and the patient has stopped dialysis and returned to work full time. So the take-home messages from this case are that one should monitor for recovery of residual renal function, because we can sometimes get fooled. Even with the biopsy, in this case, looking very bad, this patient recovered enough renal function that he no longer needed dialysis. Consider de-intensifying the dialysis prescription if renal function recovers, and remember to calculate the peritoneal KT/V based upon the number of days that the patient is actually dialyzing. Okay, let's talk about electrolytes a little bit. 53-year-old man with end-stage kidney disease on hemodialysis for 5 years, and diabetes type 2 and morbid obesity, is at a rehab facility preparing to go to dialysis on a Tuesday after having missed dialysis on Saturday. When he passes out, he is brought to the hospital where his initial electrocardiogram is as shown here. And I'll pause and let you view the electrocardiogram. So what do you think is the most likely explanation for this patient's presentation? Is it anemia, hypercalcemia, hyperkalemia, or hyperphosphatemia? Please vote. So everyone's going to get this. This is hyperkalemia. So we know that the greatest period of vulnerability to arrhythmias is after the long 2-day interdialytic interval. So it's Monday morning for our Monday, Wednesday, Friday patients, and Tuesday morning for our Tuesday, Thursday, Saturday patients. This patient has had an interdialytic interval of 4 days. He's been on hemodialysis for 5 years and likely has no residual renal function. Therefore, hyperkalemia is the most likely explanation for his presentation. So in the emergency department, the patient develops increased work of breathing, hypoxemia and hypercapnia, and is intubated and mechanically ventilated. His labs come back with potassium of 9.3. His glucose was 221, and you can see his venous blood gas showing a pH of 7.16. So in the emergency department, he gets the usual cocktail. He gets calcium gluconate, insulin, D50, sodium bicarbonate, and high-dose albuterol nebulizer while we're trying to tee up dialysis. So what potassium bath would you use for emergent hemodialysis in this patient? Would you use a 0 potassium bath, a 4 potassium bath, or would you do a 3K for an hour followed by a 2K followed by a 1K? Please vote. So there's some variability here in responses, but I think I see the most votes for C. So I would not choose a 0 potassium bath, nor would I choose a 4 potassium bath, but I would choose a gradient approach. And the reason is that the 0 potassium bath would pose too great an arrhythmic risk from lowering potassium too quickly, while a 4.0 potassium bath might not provide enough of a concentration gradient for a starting potassium of 9.3. We favor the use of a gradual lowering of the dialysate potassium in order to more slowly lower the potassium over the course of the dialysis procedure. Now, electrolyte composition isn't just about potassium. Remember also that rapid correction of metabolic acidosis may lead to a precipitous drop in the ionized calcium. Pre-existing metabolic alkalosis coupled with hypokalemia may be associated with more sudden cardiac death. So we know that ionized hypocalcemia leads to prolongation of the QT interval. There's more sudden cardiac death in patients with a pre-hemodialysis bicarbonate concentration greater than 27 in those dialysing with a diacetate dry concentrate. The delivered total buffer is the sum of the dialysate bicarbonate plus 4 for liquid concentrate or 8 for a diacetate dry concentrate. Now, there are a lot of thoughts about what the optimal dialysis bicarbonate is or should be, but very little data. This is from the DOP study, which tends to show a greater hazard ratio for all-cause mortality, as well as cardiovascular and sudden death, and interestingly, for infection-related mortality with higher dialysate bicarbonate baths. We also know that there have been a lot of lawsuits related to use of the product that contains 8 millicones of diacetate. And so I think that we should all be aware of that there may be some risk, particularly in those patients who are malnourished, coming in with pre-existing metabolic alkalosis and hypokalemia. Okay, let's move on to a different topic. In this case, we'll talk about alternate mental status a bit. 62-year-old man with end-stage kidney disease secondary to scleroderma. He's admitted to the hospital with shortness of breath. Past history notable for end-stage kidney disease, scleroderma, COPD, peripheral arterial disease, current pleural effusion, and malnutrition. In the hospital, he's diagnosed with pulmonary emboli and is started on IV heparin. He develops a pneumonia, is treated with cefepime. He develops an ileus, GI bleeding, and a sacral wound. This is a picture of that sacral wound. Dermatology was consulted, and they recommend starting the patient on IV acyclovir for HSV infection. We recommend touching base with pharmacy for appropriate dosing in the HD patient. Can transition to vial acyclovir discharge. Treatment duration will be until lesions heal. And so with pharmacy's recommendation, the patient was started on acyclovir 5 mg per kg daily. 4 days later, the patient develops altered mental status. He was sent for a stat head CT. I went to see the patient shortly after he came back from his head CT, and I noted the patient was anxious, confused, and said, and I quote, "I died down there." So, what do you think is the most likely explanation for this patient's altered mental status? Is it inadequate dialysis? Is it cefepime? Or is it acyclovir? Please vote. It's going back and forth between cefepime and acyclovir. And I will say, probably before this patient and doing a little bit of research, I would have voted for cefepime because that's what I knew. But as it turns out, this patient's altered mental status was due to acyclovir. So always think about medications when you're faced with a dialysis patient with altered mental status. These are some of the medications to think about: acyclovir, cefepime, narcotics, gabapentin, amantadine, and baclofen, amongst others. So some institutions have created these nice buttons to remind our hospitalist colleagues in particular not to prescribe baclofen in patients with CKD and ESKD. So what about acyclovir specifically? Well, what was really interesting about this patient was that he came back from his head CT and said, "I died down there." Death delusions and myoclonus are specific neurotoxicity features of acyclovir that I had never seen before. And so as I started researching, some of the features of acyclovir neurotoxicity, I knew about disturbances in consciousness, seizures, myoclonus, and coma, but I did not know about the very specific neuropsychiatric symptom of death delusions. It was first described by a French physician, and so it has a French name, which I won't try to pronounce, and the syndrome carries his name as an eponym. So in terms of management, the diagnosis may be confirmed by measurement of the metabolite 9-carboxymethylguanine. Discontinuing the drug and hemodialysis are the most appropriate steps in alleviating that presentation, because even the metabolites are very effectively removed by hemodialysis. Now, what I don't know is why this patient developed neurotoxicity. His dose was appropriate as per the usual guidelines, and he was receiving intermittent hemodialysis on a regular basis, had not missed any treatments. So I really don't quite understand exactly why this patient developed it, but he did. Okay, let's move on to a different scenario. 64-year-old man on hemodialysis presents to the ED with headache, found to have a blood pressure of 240/100. He had a similar presentation at a different hospital 3 days prior, at which time he was given his usual blood pressure medications and discharged home. In the ED, he had a head CT that was negative for any intracranial process. His admission weight was 86 kilograms. His past medical history is notable for, in addition to end-stage kidney disease, hypertension, type 2 diabetes, BPH, and CML. These are his medications. So you can see he's on a number of antihypertensive medications. In addition, he's on treatment for his CML. He's on phosphate binder and vitamins. He's on sodium zirconium cyclosilicate for chronic hyperkalemia, and he's on an ESA. So this is his dialysis prescription and history. He's dialyzing with a high flux polysulfone dialyzer for 3.5 hours. Blood flow rate of 400, dialysate flow rate of 800. His dialysate sodium is 140. Total buffer is 43. Dry weight is 81 kilograms. He does not miss dialysis treatments. His typical interdilated weight gain is 4 to 5 kilograms, and his typical ultrafiltration is 4 to 5 kilograms. So what's the next best step to improve this patient's fluid management? Would you say is to increase the dialysate sodium to 145, increase the dialysate calcium to 3.5, increase the time on dialysis, change to a larger surface area dialyzer, reduce dietary sodium intake, or both C and E? Please vote. Okay, it looks like 100% of folks have voted for the correct answer, which is both C and E. So let's talk a little bit about this. So increasing his dialysate sodium may actually exacerbate the issue of excessive interdilated weight gain. Dr. Bashinsky's on the call, so certainly don't want you to increase the dialysate calcium. That might help with the hypotension, but that's not the issue in this case, and we got the issue of vascular calcification to deal with. A larger surface area dialyzer will help with the urea clearance, but that's not the issue in this case. A longer time on dialysis may help to reduce cramping, allow him to reach his dry weight, and lower the ultrafiltration rate. And finally, a reduction in dietary sodium will reduce interdilated weight gain. So the issues with this patient are excessive interdilated weight gain. The interdilated weight gain should be lower than 4 to 4.5% of the dry weight, poorly controlled blood pressure, and a relatively short treatment time. So what is the UF rate? That's the fluid removed per body weight per unit, per unit time, expressed in ml per kg per hour. His period was 86 kilograms. The targeted fluid removal was 5 liters. 5 liters divided by 86 kilograms divided by 3.5 hours comes out to a UF rate of 16.6. I sometimes use this online UFR calculator and show patients because it has a nice graphic that shows if they're in the red zone here, that may be in the danger zone. If you have cramps, headaches, or feel dizzy, you may have organ stenting, which can cause permanent harm. To be in the green, reduce water weight to 3 liters, increase hemodialysis time, or both. So this can be a nice graphic way of illustrating to patients why we may be concerned about the ultrafiltration rate. Now, you've probably all seen this paper from Jenny Flythe and colleagues, which showed that high ultrafiltration rates may be associated with higher all-cause and cardiovascular mortality. And you can see this, fairly steep increase that begins at about 11, flattens out a little bit, but still increases as you get up to about 13 to 15. The price of high interdilated weight gain is a higher risk of all-cause and cardiovascular death, cardiovascular risk, left ventricular hypertrophy, cardiovascular events, including CVAs, congestive heart failure, and impacts patient quality of life. More extra sessions for volume control, poor tolerated treatments because of cramping, hypotensive events, etc., if we're trying to remove a lot of volume in a relatively short period of time. Now, we often talk to patients about fluid and restricting fluid, but we don't talk as much about dietary sodium as we should. And so I always emphasize talking to patients about not just about fluid intake, but also about dietary sodium. And there are a number of studies with mixed results in terms of showing that that dietary sodium interventions can improve interdilated weight gain. Okay, 2 more cases. Case 6, 59-year-old woman with end-stage kidney disease secondary to diabetes on hemodialysis for 13 years, presents to her primary care provider with complaints of itching. Common complaint. Medications include sevelamer, hydroxyzine, gabapentin, calcitriol, amlodipine, and erythropoietin. She has an adequate single pool KT over V. Phosphorus is not terrible, 5.1. PTH is 251. Hemoglobin is 10.9. She has this lesion on her lower extremity. Which of the following do you think is the most likely diagnosis of her skin lesion? Is it calciphylaxis? Is it shingles? Is it acquired perforating dermatosis? Or is it calcinosis cutis? Please vote. Getting some variations in the answers here. A few votes for calciphylaxis. Next number of votes for calcinosis cutis, and then a few votes for acquired perforating dermatosis, but that actually is the correct diagnosis. This patient has a crater-shaped nodular eruption occurring in the setting of diabetes and end-stage kidney disease. The most likely diagnosis is therefore acquired perforating dermatosis. So skin disorders are very common in chronic kidney disease. They can be a minor annoyance for some patients, but may be debilitating in others. The preferred nomenclature is now CKD-AP, not uremic pruritus. Co-management with our primary care colleagues is really critical for our patients with end-stage kidney disease because it is not possible for us to do a full skin examination in the dialysis clinic. So what are the risk factors for CKD-AP? They include things like inadequate dialysis, metabolic derangements, hyperphosphatemia, hyperparathyroidism, malnutrition, inflammation, low serum albumin, high ferritin, high CRP are risk factors. Hepatitis B and hepatitis C are also independent risk factors for CKD-associated pruritus. So what are the treatments for CKD-associated pruritus? We start with the simplest ones. Emollients should be applied to the wet or damp skin after bathing. Then moving on to topical analgesics, pramoxine can be very effective in some patients. Antihistamines, diphenhydramine, hydroxyzine, and cetirizine are things that we probably use most commonly. Cromolyn sodium has been tried and may be effective in some patients. The gabapentinoids, gabapentin and pregabalin, can be effective in controlling CKD-AP in some patients, but one has to be very careful with the dosing and avoiding neurotoxicity. And finally, the opioid agonists and antagonists are the newest agents that may be effective in dealing with CKD-associated pruritus. So this is from a New England Journal of Medicine paper looking at treatment with difelikefalin. We showed that difelikefalin was able to improve patients' worst intensity scores for pruritus and their itch scores. If you look at the mean change in worst intensity for itching, you can see that those subjects who were treated with difelikefalin had significantly improved results compared to those who were treated with placebo. What about APD specifically? Patients with pruritic to painful nodules with known risk factors probably have acquired perforating dermatosis. The primary risk factors are diabetes and CKD. The lesions may be precipitated or worsened by scratching, so treating pruritus is really key in preventing its development or preventing the development of new nodules. In terms of treatment, making sure the patient's receiving adequate dialysis, phosphate control, glycemic control, topical therapies, including things like emollients, topical or intralesional corticosteroids may be effective. Keratolytics like salicylic acid and urea may be effective in some patients. Topical retinoids have been tried. Antihistamines, systemic retinoids, and allopurinol have been tried with some success. And then finally, for those patients who have really resistant APD, UV phototherapy has been used in some instances. This is very difficult to do for our dialysis patients because they're already committed to coming to dialysis 3 times per week. Last case, this is a patient that I saw as a fellow 30 years ago, and she stands out in my memory. She's a 68-year-old woman with a 5-year history of end-stage kidney disease, long history of alcohol use disorder. She's been sober for the last year, but she still frequently misses dialysis. And when she does attend her sessions, she signs off earlier than her prescribed time. She comes into the emergency department complaining of weakness and nausea. She's missed dialysis for a week. On exam, she's a thin, elderly woman. She's tiny, 44 kilograms. She's hypertensive and tachycardic. She has basilar crackles. She has a regular rhythm, no friction rub, benign abdomen, some lower extremity edema. She's got a very large and tortuous and aneurysmal left arm AV fistula. Mental status is normal. Her labs went over for potassium was 6.1, CO2 was 16, B1 was 150, creatinine was 10, phosphorus was 7, albumin was 3.2. She had an undetectable alcohol level. So this is a prescription that my co-fellow wrote. He wrote for her dialysis for 4 hours with a QB of 400, QD of 800, and UF her to her dry weight. About 2 hours into her treatment, the patient had a generalized tonic-clonic seizure. Dialysis was terminated. The seizure broke with a dose of intravenous lorazepam. So what do you think is the most likely explanation for this patient's seizure? There's a brain tumor, dialysis disequilibrium, uremic encephalitis, or CO2 retention. Please vote. So it looks like the most votes are coming in for the correct answer. This is most likely dialysis disequilibrium. Now, dialysis disequilibrium occurs rarely, and its most severe outcome would be cerebral edema. Fortunately, that is a very rare outcome. The cases that we typically see are much milder in the modern era. What is it? It's a set of neurologic signs and symptoms that may occur in patients undergoing hemodialysis. The symptoms may be mild, headache, restlessness, to more severe disorientation and seizures. The pathophysiology is thought to relate either to changes in cerebral osmolality or changes in CSF pH, a decrease in the pH during hemodialysis. There's a greater risk in patients with pre-existing neurologic disease. So, for example, patients with strokes, head trauma, malignant hypertension. The idea is really to prevent it. And that's the reason that we don't see much of it in the modern era, is that we know how to prevent it. We start gently. Low blood flow rate, low dialysate flow rate, a smaller dialyzer. Some institutions may give an osmotic agent such as mannitol in order to help prevent dialysis disequilibrium. The problem with this case was that this patient had missed dialysis for a week, and she got dialyzed with a very aggressive prescription. And so you have to think about prevention, not just in new starts, but also in patients who may have missed dialysis for a while. So these are the summary take-home messages that I hope you'll have gotten out of these cases. Review the outpatient records to help identify long-standing renal osteodystrophy. Monitor for signs of renal recovery and de-escalate dialysis as appropriate. Gradually lower the potassium in cases of severe hyperkalemia in order to reduce the risk of arrhythmias. Review medications to identify potential causes of alternate mental status in dialysis patients. Monitor UF rates in patients with high intradialytic weight gains. Co-manage dialysis-associated pruritus with our primary care colleagues. And finally, take steps to avoid dialysis disequilibrium. And I will stop there right on time.